All right, today we are going to trace the entire story of breast carcinoma. We're going to follow it from the very first clue, a lump someone might feel, to what a radiologist sees on a scan, and then all the way down to what a pathologist finds under the microscope. We'll connect all these dots to see how they build a complete picture that actually guides a patient's entire treatment plan.
So, where does this story usually begin? Well, it often starts with something that seems almost harmless, a single lump discovered by a patient or their doctor. And the really tricky part is, it's typically painless, and you can even move it around a bit. This quiet, deceptive beginning is one of the most common ways invasive breast cancer makes its first appearance.
Now this right here shows you just how much of a revolution screening has been. Think about it. Before mammography was common, tumors were often 2, maybe 3 centimeters big by the time they were found. And in about half of those cases, the cancer had already spread to the lymph nodes. But today, screening has totally changed the game. We can now find cancers when they're tiny, often before they've even had a chance to become invasive. That's huge.
Okay, so here's our game plan for this explainer. We're going to start with how cancers are discovered and detected. Then, we'll look at the non-invasive or contained forms. After that, we'll see what happens when the cancer breaks through, we'll track how it can spread, and finally, we'll put it all together to understand how a prognosis is determined. So let's kick things off with discovery and detection. This is that all-important first step, going from a lump that someone can actually feel to a precise image that a doctor can analyze and understand. Mammography really is the star of the show here. The real magic is its ability to spot these tiny little specks of calcium, which are often the very first and sometimes only sign of an early, non-invasive cancer called ductal carcinoma in situ, or DCIS. And here's something interesting. As women get older, breast tissue tends to get less dense. This actually makes mammograms even better because tumors, which are solid, stand out much more clearly against the less dense tissue.
But, it's not a one-size-fits-all solution. For some women, especially younger women at high risk who have naturally dense breasts, an MRI can be an incredibly powerful and important tool to use alongside mammography.
Okay, let's move on to the pathology of these contained cancers. Now, these are malignant cells, but they're still playing by one really important rule. They haven't broken out of their original home.
First up is ductal carcinoma in situ, DCIS for short. The name itself tells you almost everything you need to know. In situ literally means in its original place. The cancer cells are there, inside the breast ducts, but they're completely walled in by a structure called the basement membrane. They haven't broken through.
And here is where the clinic and the lab connect perfectly. Under the microscope, certain types of DCIS, especially a high-grade one called comedo, have a center of dead or necrotic cells. It's this debris that calcifies and boom, that's what lights up on a mammogram. Now sometimes, these DCIS cells can actually travel up the ducts all the way to the skin of the nipple, which causes a condition called Paget disease. It just looks like a reddish, crusty rash.
Now for the other main type, lobular carcinoma in situ, or LCIS. In this case, the abnormal cells are in the lobules. That's the part of the breast that makes milk. The key thing a pathologist sees here is that the cells are discohesive. They just don't stick together very well. They fill up the lobules, but the overall structure of the lobule usually stays intact.
This table lays out the differences beautifully. DCIS, usually found on a mammogram because it calcifies. LCIS, it almost never does, so it's usually found by chance during a biopsy for something else. But here's the most critical difference for a patient's future. DCIS means there's a higher risk of getting invasive cancer in the same breast. LCIS, on the other hand, is a warning sign for a higher risk in either breast, and that difference is key to how doctors manage it.
And this brings us to the moment everything changes: breaking through. This is the official definition of invasive cancer, when those cells finally breach the basement membrane wall and start invading the tissue around them. This is when something found on a scan can become that firm, irregular mass you can feel.
Now, once a cancer is invasive, pathologists give it a grade from 1 to 3. You can think of it like a report card for how much the cancer still looks like normal breast tissue. Grade 1, or well-differentiated, is the best behaved. The cells are still pretty organized, forming nice little tubules and glands. They all look very similar to each other, which usually means slower growth.
Grade 2, as you'd guess, is the middle ground. Things are starting to get a bit more disorganized. You see fewer of those nice tubules and more just solid clumps of cells. And the cells themselves are starting to look more varied in size and shape.
Pathologists call this pleomorphism, and it's a sign of more unpredictable behavior.
And finally, we have grade 3, or poorly differentiated. These tumors look the least like normal tissue. It's basically chaos. The cells are growing in disorganized sheets. They look very different from one another, and you can see a lot of them actively dividing, what we call mitoses. It's a clear sign of rapid, aggressive growth.
So what's the bottom line here? It's simple, really. What a pathologist sees under the microscope is a direct reflection of the tumor's personality. The more organized and normal it looks, with lots of tubules, the better the prognosis. The more chaotic and disorganized it looks, the more aggressive it's likely to be.
So once those cancer cells are invasive, they've basically gained access to the body's superhighways, the lymphatic system, and the bloodstream. So our next step is to figure out how to chart the cancer's spread, from the lymph nodes right next door to organs far away.
There are two main routes they can take. The first, and most common, stop is the lymphatic system. Tumors on the outer side of the breast usually drain to the axillary lymph nodes, the ones under your arm. Later on, the cancer can spread through the bloodstream to places like the lungs, bones, or liver. It's important to know that this can happen years later, but with every year a person is disease-free, the chances of a true cure go up.
So how do doctors figure out if the cancer has started this journey? They use this absolutely brilliant concept called the sentinel lymph node. Think of it as the guard at the gate. It's the very first lymph node that the tumor drains to. The whole idea is, if the cancer is going to spread, it has to pass through this node first.
And here's how it works in practice. A special tracer is injected near the tumor. It travels through the lymphatic channels and lights up that first sentinel node. The surgeon can then find and remove just that one node. The pathologist checks it for cancer. If it's clear, it's very likely all the other nodes are clear too, which saves the patient from a much bigger, more complicated surgery.
All right, let's bring this all home. We've gathered all these clues, from the mammogram, from the biopsy, from the surgery. Now it's time to put all the pieces of the puzzle together and decode the prognosis, to figure out the likely course of the disease.
And when it comes to prognosis, not all factors are created equal. There's a definite hierarchy. The single most important factor is whether the cancer has already spread to distant organs. If it hasn't, the next most important thing is the status of those lymph nodes. After that comes tumor size and the grade we just talked about. And finally, we look at the tumor's specific biology. Does it feed on hormones? Does it have a protein called HER2 that fuels its growth? So you see, in the end, that pathology report is so much more than a piece of paper. It's the roadmap. It tells you the cancer's past, that's the grade. It tells you its present location, that's the stage. And it helps predict its future, that's the biomarkers. Every single piece of that report helps guide the very next step in a patient's treatment.
And that really leaves us with a question for the future. We've already come so far from just feeling a simple mass to understanding its complex molecular profile. So as our knowledge gets even deeper, how will this microscopic roadmap change and evolve to create treatments that are even more personalized and even more effective